Good afternoon, everyone, and welcome to this policy panel on long-term care and COVID-19. We're so glad you could join us today to talk about this very serious subject, one that a lot of us can sort of relate to, and one that's touched a lot of us across the country during this pandemic. My name is Carly Weeks, and I'm a health reporter with the Globe and Mail. I've been covering COVID-19 for most of the year and all, throughout the second wave, just sort of witnessing what's going on as we watch with a lot of concern what's going on again in long-term care homes in Ontario and across the country. I'm going to introduce our fine panelists in a moment, but I just wanted to sort of start by setting the scene. COVID-19 has obviously impacted everybody sort of around the world. It's, literally a truly unprecedented event. And it's very, I think that's probably the most overused word of the year other than pandemic, but it is true. But long-term care homes and long-term care residents and staff have felt this issue probably the most anywhere. And we know that obviously the statistics coming from Canada are quite grim, that our long-term care deaths make up the vast majority of COVID-19 related deaths, and that Canada has sort of the very dubious distinction of having I think it was still the highest rate of mortality linked to long-term care homes and seniors. So obviously a lot of problems that were exposed in the system and issues that have sort of been long-standing that have yet to be addressed or still, remain outstanding. Issues around how residents are cared for, around facility design and lack of private rooms, the support workers who work in many of these homes and the issues around training and even compensation. Even something as simple as making sure that a lot of staff members know how to properly don and doff PPE became an issue this year. So we're going to dive into where we're at with COVID-19 and long-term care. Are we better prepared now that we have this second wave coming? What are we already starting to see as, case counts in long-term care and outbreaks in long-term care facilities climb? So I'm so happy that these two guests are here to help walk us through some of these complicated issues and answer our questions. We will have a little bit of time for questions at the end, and I'm sure that many of you have some. So I'll stop talking and basically introduce our two guests for today. So we have Dr. Dawn Bowdish, who is the Canada Research Chair in Aging and Immunity at McMaster University. As well, we also have Andrew Costa, who's Assistant Professor and Research Chair in Clinical Epidemiology and Aging at McMaster University. So I'll just open things up by throwing right to you guys. We're obviously in the midst of a second wave. It's, scary what's going on out there. For many months, though, we've been hearing more about how the cases are kind of impacting the community. Younger people are being affected, but more recent statistics paint sort of a darker picture. A lot of people in their 80s and up being infected, a lot of long-term care outbreaks. Maybe you just can set a bit of a scene for us where we're at with COVID-19, how it's impacting long-term care, and what you think is to come. So whoever, Dr. Bowdish, why don't you start us off?
Sure. Well, we always knew it was a matter of time when we saw this big surge in the 20 to 30 years old. We saw after Mother's Day, we saw a transfer of cases from that sort of young adult to sort of mom age individuals in the 50 and 60s-year-old, and a bit of a spike with regard to long-term care, because as families get together, inevitably there's a transfer. So as we were seeing in the late summer, as we were seeing these cases increase in 20 to 30-year-olds, that was really a time that we should have spent doing contact tracing and trying to eliminate those, because inevitably what's happened now is we've seen this spread to the broader community. And unfortunately, our younger working age adults, people in their 20s, 30s, and 40s, they tend to have more social contacts. They go to work and they see people, or maybe they work in long-term care. And so it was inevitable that we would see this spread now. And unfortunately, we're in the dubious position now of having many, many, many outbreaks in long-term care facilities in Ontario. And we are expecting to see rises in deaths. And death is what we call a lagging indicator, means that people get sick first, and then there's hospitalizations, and those can be quite protracted. And now we're starting to see death rates increase.
Andrew, feel free to jump in and give us your take. And I know that maybe you also want to mention some of the findings that you've had around for-profit care homes as well.
Sure. Yeah, it's been sort of a tale of two waves, and we have fairly good evidence around spread characteristics of COVID in Ontario from the first wave. So myself and a team working with the COVID-19 consensus modeling table for the province, we've been looking with the data available at what facility and community level characteristics have been associated with outbreaks and severe outbreaks. And we published some work on it. There was a piece published in CMAJ where the main exposure we focused on was particularly the debate around for-profit status, because that was still is and was then a very large debate. But really, it was a study that looked at community as holistic as we could, explanatory model for community and facility characteristics that are associated with outbreaks. And what we had found was that essentially, and not a huge surprise, was characteristics that inferred risks associated with the number of vectors were obviously associated with outbreaks. And so having a look at this slide, this is from the paper. If you look at the fully adjusted model, which is what's highlighted there, it's absolutely clear, and it's clear today that the in scheme of incidence of COVID-19 in the surrounding community facility is incredibly deterministic in terms of the risk of an outbreak. And that's sensible because it needs to come from somewhere. And of course, it comes from the community, not from the long-term care facility. And it's also been very clear that it comes in with staff, particularly in wave one, where there was an early lockdown of visitors or restrictions from visitors, as well as other restrictions that meant that the interaction that long-term care residents were getting were mostly from staff. And so if it's in the community and particularly at certain thresholds, it's very likely that it will emerge within facilities. And the evidence around the time dependence between community incidents and then outbreaks in long-term care is somewhere around 23 days in Ontario, but it's highly regional. Beyond that, if you have a larger facility, you're more likely, in this case, is the extent of outbreaks, but in the previous slide looks at outbreaks in general, you're more likely to have an outbreak. And that makes sense because the larger the facility, the more residents in the facility, the more staff required to deliver care, which means more vectors. And so again, deterministic element is vectors. We also found that design standards matter, particularly when you look at the scale of outbreaks. And so larger outbreaks were associated with facilities that had older designs. And so the main feature of these designs, which essentially were from 1970 in Ontario, were that they had ward-style bedrooms with 3 or 4 residents, not often 4, mostly 3, shared bathrooms, as well as more tight, cramped common space in the facility. Whereas the new standards, and they're not very new, but they're essentially 1995 forward, they don't have those. It's a maximum of 2 residents per room, a separate bathroom for each room. As well, they have, you might describe them as units, what are called resident home areas, where you don't have more than 32 to 40 residents in a unit, which means you can control spread much better. So for those facilities that had those design features, they were more likely to see an outbreak. That's still true today, and it's part of Ontario's risk modeling system for long-term care. And so that is still true today. What we can't measure is certain staff characteristics, and what we can't measure as well as leadership. We know it's an important part. Right. And this figure, for instance, you're seeing here old and new design. You're also seeing chain ownership, which is also important, which we think the mediating factor there is essentially staff, the frailty of their staff complement, lack of longevity among staff that's associated. But here you look at across ownership status here, facilities that are in red were the older facilities. You could see much more likely to have larger outbreaks. And amongst the largest outbreaks in the province, they, to this day, still, for the most part, remain older facilities.
Wow. I mean, it's obviously, it's really disconcerting. And, we've heard from numerous organizations over the past many months that these are not even new issues. I mean, as you point out, like these are things that have gone on for years and years, and we still have plenty of homes with, as you mentioned, the ward style beds and things like that. I was wondering if perhaps maybe you could both touch on some of the other long-standing issues that make homes just so vulnerable to these kinds of outbreaks, and then perhaps what needs to be done to address this. I mean, as you mentioned, there are new design standards from the 90s, new-ish design standards that, obviously, some homes have, some homes may not. What other policy things do we need, to address some of the gaps, some of the vulnerabilities in this system? So Andrew, maybe you want to start us off there, and then Dawn, please join in after.
Yeah, it was frankly a powder keg waiting to happen. And as the pandemic was emerging here in Canada, there was a lot of focus and attention on what would be, it's hard to imagine, seeing what was occurring in Italy. The concern was around hospitals being overrun. For those of us that have done work and been concerned with long-term care for quite a long time, we knew it was going to be a very, very large issue. And so it was. The sector has received under attention for a great number of years, where institutionalization and has been a focus. It's part of probably a broader ageism and lack of attention to the healthcare system. There's been chronic issues really across the board, regardless of ownership model, of vulnerable staff groups, low-skilled staff groups that make up the majority of capacity, a lot of part-time work, and basically not a lot of focused attention and upgrades to the sector from really any source.
Wow.
Yeah, I would just add that we've known this is a problem for decades. I mean, we have incredibly high death rates from respiratory infections in general in Canadian long-term care. So influenza deaths, for example, have often been extremely, extremely high. And I can think of examples from my own research program where some years we had long-term care homes where there were much higher number of deaths from respiratory infections than there should have been. Pre-COVID, though, people thought that this was just part of being old. And in fact, what I think Andrew's demonstrates so elegantly is that these are ageist, really. Our lack of prioritizing the health and well-being of our oldest and most frail adults have led to increased mortality for a long time. And until we fix this, and hopefully COVID will be the lens that we need to look through to really reflect and fix this, we will see that there's continued mortality and loss of life associated with infections of all different origins.
Yeah, and it's unfortunate that it's basically taken us to this tragedy, to get to this point where we're even having that discussion. Certainly. I wanted to pivot to something that, we're still working on, I guess, across the province and across the country to try and address some of these outbreaks, and that's testing. Maybe both of you, and Dawn, please start us off if you want to, can talk a little bit about where we are at with testing. And there's been no end of controversies around testing. Who do you test and when? We now have a lot more regular testing of residents and workers and things like that. But the Ontario government also announced, I think yesterday, that they have new rapid tests that they're going to be deploying. So I would just wonder if you could share your thoughts on where you think we are with testing, what some of those gaps are, and then maybe about these rapid tests. Is this sort of the lifeboat we've been waiting for?
Sure. So I have very strong opinions, and you're about to get an earful.
Excellent.
One of the issues in the early days of the epidemic, when we were out of everything, we didn't have any swabs, we didn't have any of the reagents to test that, is we had to make some pretty conservative decisions about testing. And even though we now know that in the regular population, forget long-term care, but in the regular population, about 50% of the infections are transmitted from asymptomatic individuals, there's still not been a good focus on looking and finding those chains of transmission, which is very different than other countries that have successfully done this. So instead, what we've done is we sort of moved towards symptom-based testing, looking for people who are looking at or have symptoms. And one of the problems with doing this in the long-term care is a lot of the things we feel, the symptoms we have, are immune responses to the virus. And so older adults and frail adults don't have the same immune system, so they don't have the same symptoms. And there've been a number of studies now that have shown that if we go through our little provincial checklist about what sort of symptoms should send you to a testing center, if you look in older people, they're not going to hit those criteria in the same way. Most of them will have mild symptoms, or they'll have unusual symptoms, lots of GI things or abdominal issues and things like that. And so they're much less likely to report even the loss of smell and taste than people who are younger and have more intact immune systems. So symptomatic testing is a complete loss in the context of long-term care. We need to do what we call surveillance testing, which is frequent testing over time. And I put this graph together for you first, because one of the insidious things about this virus that has let it spread out of control is it's got this long sort of what we call the pre-symptomatic stage. So with an influenza infection, you only have a day or two before you start showing symptoms. So hypothetically, if this was like that, our contact tracers would only have to look back 48 hours. But with COVID, there's actually a 5-day window in general, and it can be longer, where people don't have any symptoms. So you've got these two courses of infection that I've outlined in the blue there. You've got this long period of asymptomatic, and then people go one of two ways. They either have the really mild, and God forbid, they may actually come to work because they think I just have a cold, it's just allergies, I stayed up too late last night, I had a bit much to drink, very, very minor symptoms that are easy to write off. And then you can go into these two different pathways of getting better or not. But here's where it's also problematic. The testing that we do right now, that deep nasal swab that you've seen on the TV, tests the amount of, can we go back one slide for 1 second? It tests the amount of the virus that's in there. But as you're sort of building up, the chance of having a negative test is very high. So in that green square that I've outlined for you, that little dot says, what are your chances of showing up negative even when you're actually positive? And you can see that testing in the first 3 days is not very helpful. And this is why now we recommend if someone's had an exposure, they get a test as soon as they know, and then 3 days later, because if you see that after 5 days, all of a sudden it starts getting a little bit more reliable. But I want you to imagine right now, if you're in the field of long-term care, most of our testing of workers has been every 14 days. So imagine you have a person who's never going to show any symptoms, who's asymptomatic, and you happen to catch them on day one of their infection. They're going to probably show up as negative. Now you're going to wait a full 14 days till you test them again. You will have completely missed that highly infectious period. And having testing for 14 days is really very problematic. And we need to have more frequent and rapid testing of people to catch those windows where they might be infectious. And if you could just go to the next slide. So what have we got right now with regard to testing? Well, we've got this deep nasal swab that can be used, and we've also got saliva testing. And so I won't go through this unless there's questions, but essentially we can do deep swab testing. But as you can well imagine, most people cannot tolerate that. And certainly people who are doing it for surveillance testing more than once a week find it extremely uncomfortable. And so many of us, including myself, are trying to move to studies where we do frequent saliva testing. Everybody can spit, well, not everybody. Some of our oldest, frailest residents find it difficult, but healthcare workers and people working in these homes are happy to spit in a tube once or twice a week and get tested that way. And that way we can expand our testing strategy. So my take-home message with testing is, if you're only looking for symptomatic people, you are missing and causing infections, because in long-term care, most of that infection is transferred by asymptomatic individuals. You have to have surveillance testing, and you have to have frequent testing, because we're just missing too many of these latent infections that are leading to spread.
Andrew, I'll ask you to jump in a second, but while you're on that note, I wanted to ask you about the rapid tests. So these saliva tests are supposedly here and they're coming. We know that there's also a high sort of, they're not as accurate as we want them to be, right? There's always trade-offs. So rapid means maybe not as accurate. So what could that do? Is that going to be this change that we need? Or do you still think we just need to do more frequent nasal swabs?
Yeah, so the recent rapid testing, let's be clear, the world is imperfect. There is no perfect solution. And I will always favor more testing over less testing. to a point. The problem with the recent antigen testing that people have decided to include is they still require, in many cases, a nasal swab. So you don't get over the hurdle of doing that. And their false positive rate is quite high. So for example, by some estimates, it's believed that you find somebody, you tell them have COVID, half the time you're wrong. So they still need to go for a follow-up for a second test. And of course, now we've moved to having them have 2 deep nasal swabs, where having just one. And, when you think about our healthcare workers who are so stressed and so strained, and the tremendous stress and worried getting a false positive has on your family. I mean, just imagine what your family life would look like if you were worried about infecting the people around you. It's a lot of mental stress. So my personal preference is the low false positive rates of frequent saliva testing, but the issue with that is it's not available everywhere. It's not a provincially licensed test that you can go and donate. So it's going to be a tough solution to implement.
So Andrew, please share your thoughts on, testing, the many problems that we still seem to have even this many months in, and where we should be headed next.
Testing is really important to feature. Obviously, with better testing, we think we can have better prevention and particular management. I think what we've seen from wave 1 to wave 2 is we have better testing. It certainly has a long way to go. I think that and other features has led to, compared to wave 1, less outbreaks and severe outbreaks than what we otherwise would have expected, given the same level of preparedness. So I think the long-term care sector, given what it's had to work with, I think we should cautiously congratulate them on the good work they've done, because it's been obviously a struggle. And so beyond testing, which is a really important characteristic, although not foolproof, there are other important strategies that are also not foolproof. When you start to add them up, you start to really decrease the probability of an outbreak or a severe outbreak. And so those things are obviously having very good PPE, very good practices around PPE. Having cohorting, where you have the same residents being looked after by the same staff, ideally, and this is particularly achievable where you have newer facilities with newer designs, you're able to cohort much easier because you have natural physical breaks in the facility and within those units, so to speak, or resident home areas. And when you start to add that up, you start to have a pretty formidable line of defense.
We talked briefly about how, symptoms in the long-term care population among residents is not your typical sort of set of symptoms that you would apply to the rest of the population. My understanding is we still don't really take that into account oftentimes. And, perhaps you guys can inform me a little bit better on that. This seems like a policy, sort of change or update, like being a little bit more flexible, just in terms of making sure that there is that sort of greater, whether it is surveillance screening or whether it's more, just adapting sort of the symptom checklist. I mean, would that help at all? Or is that kind of a moot point this far down the road?
I favor testing no matter how minor symptoms are in long-term care, in the community, in schools, because we know that the diversity of the symptoms that come with this infection is great, and different people, young people and older people, tend not to fit as well into our checklist. So again, I think it's a combination of surveillance screening and long-term care. So there's a great study about a home that thought they had a contained outbreak. And then they went and tested everyone in the home and found 92% of the people were actually positive at that point. So had they been looking for symptoms, these people wouldn't have passed the symptoms. And let's also keep in mind the spectrum of ability to communicate symptoms that some people in long-term care have. A patient with dementia might have what we call deliria, which is sort of a state of hyperactivity. Most people might think that was caused by some of their other conditions, and not realize that in older adults that's a very frequent consequence of having an infection. And so having a great geriatrician on site, somebody who really understands what infection looks like in older adults. But I completely agree with you, Carly. We need to make sure that testing is available, no matter how slight or how problematic or how minor that symptom is. And we need to include the gastrointestinal symptoms in our long-term care screening.
Mm-hmm.
Seems like an easy enough fix, and so, yeah, you do wonder what it would take to get those implemented. Andrew, did you want to jump in, or should we move on to the next question?
Oh, just that some of the comments matched the experience of folks trying to prevent and manage outbreaks in long-term care. When they do find with symptomatic screening or with the existing screening schedule, which is staff using NP swabs every 2 weeks, and you hope you have good adherence to that. It's not always excellent. Once you've established that you have a few cases, the experience in those situations, and in particularly the bad situations, is that if you think you've got two and you've got two tests back positive, you've got a lot more, and it just quickly scales to the point where it's unmanageable among staff and residents. And when that occurs, and you hope that you have natural breaks in your facility where you are cohorting in that situation, where you do have good PPE, where it hasn't gotten out of control. But to the extent that those aspects of your prevention and management fail, then it could be a very big blowout, and you lose your capacity to care for even your existing residents, those that are sick and those that are not sick, because staff have had the infection and are no longer able to work. And those things are those situations we really want to avoid. And with better and more frequent testing, that will go a very long way.
So in addition to testing, and this is actually a question that we got and something I wanted to ask you about as well, so I'm sure others are wondering the same thing. We knew in wave one what happened in long-term care, and yet we're sort of doing it all over again. So in addition to testing, that is still clearly a problem. What are the other things that you think are maybe not easy fixes, but things that we could be doing or should be doing right now to keep COVID-19 out of those facilities, or if they get in, to keep the damage minimal? I mean, obviously cohorting is one strategy. Other things that can be done, is it just about room design and cohorting, or are there other things that can be done? And Andrew, since you did the study, I'll ask you to maybe jump in first, and then Dawn, please share your thoughts.
Yeah, the hard part when we do these studies is we're looking for differences amongst existing facilities, differences in structure, differences in practices, differences in the surrounding community, in order to discern which one of those differences is important for inferring greater risk of outbreaks or severe outbreaks. The problem is that when you look at just differences, relative differences, you sometimes create undue focus, and you lose focus on what are the larger systemic issues that we still have not addressed. And the largest issue that we still haven't addressed, and anyone in the sector can see this plainly, is the frailty of the staffing system in long-term care. The fact that it's very difficult to gather a living wage if you work in long-term care, particularly as a personal support worker. These individuals are oftentimes women with children, marginalized groups that predominate there. They have access, to the extent that they wish to pursue it, they have difficulty getting full-time work. That's been improved now with policies where staff can only work at a single facility, but oftentimes they don't have paid sick leave, which gives them disincentives to come in when they're maybe experiencing minor symptoms. And these are huge issues. And so we need to, number one, stabilize the workforce, which was done so well or much better in British Columbia in wave one. It still is the focus, because we really, in order for us to up our game organizationally in long-term care, we need more staffing, we need better trained staff, and we need it yesterday.
Yeah, I couldn't agree with Andrew more. I think, it's upsetting now that we have had to have this brought to light in this way, but he's absolutely right that having people travel and be underpaid, work multiple jobs has always led to excess of deaths. So that's always been there. And I guess the biggest thing we have to do is keep community rates low, because if we have no COVID in our community, it doesn't come to our long-term care. And many countries, the ones who've been really serious about getting community rates low, have incredible testing and tracing strategies to find all those chains of transmission. And we have not. We're seeing lots of infections associated with schools, and yet we're not testing all the people associated with those classrooms. We're asking for symptomatic people to get tested as opposed to looking for people with exposures. And so we really haven't made the commitment to the test and trace strategy that other countries that have effectively dealt with this in their communities have made. And until we make that commitment, we're going to be lost.
Yeah, I think distressing is certainly the right word. When you sort of look at what's happening, and months ago, experts such as yourselves were warning us, this is what's going to happen if we don't take these steps now. And to sort of see politicians and others sort of stand up and just wait and see and hope and pray that this gets sorted out is obviously, very distressing. So that's, you touched on some really important points there. And perhaps we will see some more change to come. Hopefully we do change for the better. But yeah, it's definitely a frustrating point. And, to that end, staffing, that's obviously a big issue, something that, policies can address maybe tomorrow. I'm not saying they will, but they potentially could. Building design is obviously a whole other one. And there was a question about this, and one that I have questions about as well, which is, and I've long wondered about this, from an infectious disease standpoint, we know that having more than one person in a room increases your risk of contracting, any sort of infection multiple times. And, Andrew, you mentioned the 1995 standards, basically saying, no more than 2 to a room. I've talked to infectious disease experts who say it should be private room only, private room, private bathroom. Here's how you design a better hospital, a better long-term care facility. Certainly we've seen, hospitals getting better at that, but we still have plenty of ward beds in hospitals. Long-term care obviously is governed in a different way and has many other problems, but even from that design standpoint. So the question that came in, so please answer this part about, we have these standards from 1995. What would it take to have all homes be brought up to that sort of code? And what is standing in the way of just, is it all about money, but basically getting all homes on a really, good infection control sort of playing field? Is it just that it would cost too much to tear these places down and start from scratch? So Andrew, tell us your thoughts on that. So these 1995 standards, but also how do we get safer homes for these poor, vulnerable folks?
Yeah, I think, as a society, we need more investment. And I think we haven't prioritized investment in the sector for a long time, and it's overdue. And I think everybody should be asking themselves, because the absolute probability that any one of us listening would, in their lifetime, require the kind of intensive congregate care that is frankly only provided in nursing homes or in congregate style environments like that, because you want efficient access to resources, monitoring, et cetera. Ask yourself what you'd want. How many hours a day of support do you want? Do you want a bath a day? Can you go without a bath a day? I don't think you can. These are the things you should ask yourself, and that should direct your care. What kind of environment do you want to be in? Do you want to have 2 neighbors right next to you? I don't think so. What does that do for sleep? What does that do for your quality of life? The nice thing is where we improve our infection control, which is a priority today, we're benefiting in terms of quality of life. They go hand in hand. So they're great investments. What would it take? We still see 3 and 4 bed residents to a room, because in some of these facilities that have not been decanted for reasons related to COVID outbreaks, for these residents, there aren't other options for them to go to. It's a capacity problem in the system. And so we still see it. We did in work that we have done, we basically looked at some projections, and I'll look at them on my screen here so I'm a bit more precise. But in the first wave, we could have prevented 1,000 infection and about 300 deaths if all 4-bedroom ward rooms were switched to, and this is like a minimum standard, I wouldn't think it'd be the standard, 2 bedrooms. That would basically require 5,000 new beds. and we have currently about 70,000 beds in the province, a little less than that. If we had 30,000 new beds in the system, where every individual would have a private room, that would have prevented, based off of the wave 1 data, about 500 deaths in long-term care, a substantial number, and a good proportion of the deaths in wave 1, and about 1,600 infections. But that is also a very, very large investment, capital investment that we need to make. It will be expensive, but it's long overdue, and we really can't avoid it any longer.
Mm-hmm. Dawn, please share your thoughts as well, if you care to.
I don't have anything to add to that. I mean, Andrew said it's just a matter of human compassion. Think about how you would want to spend your twilight years, and how much dread many people as we get older feel about having to make that decision about putting our someone we love into long-term care. And I think that should be what directs us into doing the right thing in this case. And I think hopefully this will be the impetus to do that.
Mm-hmm. We have a couple of other questions coming in, so I'll just invite anyone, if you do have a question, we'll try and get to them all. We have, just under 10 minutes. I wanted to quickly ask you both, if we're like, one of the issues that came out again in the first wave was, caregivers basically being shut out altogether. These poor residents are, left on their own, and in often cases dying alone. Have we gotten better in the second wave of modifying some of those policies? And I guess the reason why I ask is, we've talked for so many years about patient engagement and how important it is to put families first, and yet as soon as this struck, families were gone and patients were on their own. So can you just briefly touch on that? And Dawn, you're nodding, so I'll go to you first.
Yeah, I find this is going to be incredibly problematic, and we're going to see long-term consequences of this. So we know that what's one of the best ways to minimize the impact or development of dementia? Social contact. We need to make sure that older adults are mobile so that they don't lose a lot of muscle mass. And there are so many consequences to the changes we've made. And I have so much empathy, because a lot of the informal caregiving comes through family visits, right? They can help and support their loved one. And in the context of a lockdown, of course, that this sort of falls on the staff to do that. So, not only will we see the tremendous effect of this, but we will definitely see follow-on effects about the health and of people living in these long-term care facilities. And so as soon as we can take Andrew's advice and build better facilities and keep infections out, the better the overall health we'll see of our elders. So I leave it to him to provide specific recommendations, but as an immunologist, I can tell you in great detail, the more social isolation people have, the more stressful humans find that. So humans actually respond to loneliness by making stress hormones, and that actually makes us more susceptible not only to infections but all sorts of other poor health outcomes. And we know that one of the best ways to keep older adults healthy is to have lots and lots of social participation. So now we're in a situation where we have to deprive them of that to keep them COVID free. It's an untenable situation. Tragic.
Andrew, did you want to jump in on that point?
It's a obviously very tough ethical issue that we've been grappling with as a society. All things being equal, having informal caregivers and family enter facilities does increase the risk, particularly if there's a community transmission occurring in the surrounding community. It's a risk that I think many people and individuals in long-term care, those that can consent to have a choice, would take that choice. And the question is I think we can do it safely. Right now we have an essential caregiver program where essential caregivers are designated. They are meant to show testing results, but it's really not an ideal situation. I think if we had better and more immediate testing at source more frequently, that designated essential caregivers would feel more comfortable entering facilities. They feel more confident that I think facilities would be a lot more confident in welcoming them in, and we could really drastically reduce the potential risk associated with that and have all the benefits.
Mm-hmm. Okay. We only have a couple of minutes left. So there's two questions. I wanted though to ask you as well, and this is sort of, it goes along with what we've already talked about, but we talk like sort of the idea of caregivers and patients being brought to the table and that kind of thing. And, you know, as we look to develop better, sort of a better pandemic response, you know, who should, you know, officials be getting in touch with and contacting, like, that they haven't been doing? I mean, I don't know. And that's been one of the issues. We don't know who they've been consulting with for the most part. So, you know, if you had to just quickly, you know, assemble that task force, like, who would you make sure is on it that's, you know, we don't think is there now? Dawn, why don't you go ahead and quickly, we'll get to the rest of the questions as well.
I have a few people who I would immediately name as experts in the field, but I don't know if they'd appreciate me nominating them to join a task force that does not yet exist. But certainly, I mean, it has to be a combination of, in this case, we need to have geriatricians and medical directors to talk about feasibility issues and we need to have people who understand how infections spread in long-term care and how the frail immune system and the dynamics of the immune system in frail individuals works differently. So a lot of the assumptions we make by looking at the rest of the community just don't apply, like the symptoms I told you about. And so those are the kind of people who I would like to see at the table. And if you'd like, I'll make you a list of people to invite to this soon to be generated task force.
Excellent. Hopefully it's not a fictitious one much longer. Andrew, what do you think?
To me, I would support the principle of task forces, and they do exist at a more of a local level. And the kinds of partnerships that we're seeing between hospitals that have more capacity around infectious disease, IPAC, et cetera, with long-term care homes. And there's been a lot of good work happening in terms of preventative consultation as well as response, so that we don't have runaway train situations where, like we had a little bit in wave one. And so far, I think that's made a good deal of difference, or at least informally, I think it has.
Okay. One of the questions that's come in, so we've heard about wastewater testing, you know, in places like Ottawa. It's been quite eye-opening. Would there be a benefit applying that in sort of these smaller areas, smaller communities, places where you have, you know, like long-term care residents living? Would that be a good part of a pandemic response here?
Yeah, I can speak to that. So the wastewater testing kind of gives us a bit of a sense of where the virus is at the community. So for example, it's very useful when, especially imagine a few months ago when we were in that stage where there were a lot of people who were in their 20s and 30s. A lot of those people would be asymptomatic. So wastewater testing can give us a better sense of people who wouldn't naturally go in to get testing and saying, what does the community level look like? And I've definitely seen some proposals to sample from actually specific long-term care communities, because then you can sort of find hidden infections that you might not be seeing. It's not as helpful because it doesn't tell you who, you know, and it doesn't even tell you in the context of, say you were able to look at one long-term care community. Is it the residents? Is it the staff? Is it the visitors? You know, it would be anyone using that sort of wastewater. So it definitely has benefits for understanding latent community infection levels, especially as an early warning system. Whether we can use it to make decisions in specific homes, I'm less clear about.
Okay. And another question, you know, when we just finished talking about the impact of isolation and loneliness on these populations, and it's obviously, I mean, how many of us have read stories about, you know, seniors who were once full of life and vibrance only to succumb to COVID-19 or another ailment after being isolated for so long. So in addition to sort of having or maybe improving on the caregiver program that's in place in Ontario and elsewhere right now, are there other ways to support these residents, other things that are being done to make sure that they're sort of staying connected, vibrant? Like, are there anything else that that you've heard of or that you wish to see? So maybe, I don't know who wants to jump in first there, but maybe Dawn, like if you have a sense, and then Andrew, if you wanted to add to that.
My kids have started a pen pal program with one of our local retirement communities. They used to go visit them as a classroom, and so now they're doing that. So, you know, having these sort of creative approaches. There have been some interesting stories about northern communities starting new sort of programs where people could be socially active and making new games and activities for long-term care residents. But in truth, I think it's a real challenge. And again, anything that we ask to put in place, I worry that that's an additional burden on an already stressed system. And Andrew can certainly speak to the incredible frailty of the entire system. I don't know, Andrew, if you have anything to add to that.
The emerging evidence on the impact to residents during particularly lockdowns is pretty mixed, and it seems clear that where there hasn't been grave infections and the quality of the facility is quite good, that residents have done okay, and in some cases slightly better on some metrics because they've gotten a lot of focused attention. There's been for those quality facilities. Obviously, it's a very mixed story because we see the opposite in lower quality facilities, and it is a function of staffing levels. If you want to increase the quality in long-term care, you increase staff. It's a perfectly linear relationship, and it's a really easy solution, actually. Just have more staff. You'll have more quality, and that way residents are getting the attention they deserve, the attention they need, and whatever can be augmented by family that would come in the facility is all the better.
Mm-hmm. Well, we're out of time, and I could keep going on about this all afternoon, as I'm sure you guys could as well, but you have busy schedules. So I'll end the panel here just by saying thank you so much for joining us, because this has been a terrible year for most people in the country. But yeah, what's gone on in long-term care has been sort of a national tragedy, and you can only hope that the powers that be will make the changes necessary to stop this from unfolding again, and even during a regular flu season, from protecting those vulnerable people living in those facilities. So once again, thank you both so much for joining us and taking part in this amazing discussion. And yeah, everyone just stay safe. Thank you for taking part. And I also wanted to thank the sponsor of this event, which was GSK. So thank you again. And yeah, everyone, hopefully the second wave will come to an end very quickly. Thanks for joining us.
Thank you.
All right, thanks guys. Take care.